I welcome all the delegates and I request our President Dr. Jitesh Mehta to say a few words for all the delegates.
Thank you, Kajal. A very good morning and a warm welcome to all of you to this webinar of IMA Mumbai branch. Today's webinar is entirely on oncology, and we have wonderful speakers with very, very interesting topics. They'll be talking on very diverse topics of oncology, and I'm sure we will be enjoying this webinar. Our next webinar is on Wednesday, that is 23rd of this month. It's an odd day, and we shall be having that webinar in the afternoon time. There will be 3 speakers, and it will be on allergic rhinitis. So I request all of you to attend. We'll be sending the link to you. On the 10th of April, we are going to have our installation of the new president, and we welcome all of you, those who want to attend that function, which will be in the evening on the 10th of April, to please register with IMA and then attend the program. So the program will be installation and followed by a fellowship dinner. I shall now hand over the mic to Dr. Kajal Ahuja to further the proceedings. Thank you.
Today's first speaker is Dr. Udip Maheshwari, and I'll request Dr. Kashyap Dakshini, who is a member of IMA CGP Mumbai sub faculty, to kindly introduce the Dr. Udip Maheshwari.
Dr. Udip Maheshwari is a consultant medical oncologist at Mumbai OncoCare Centers as well as Kohinoor Hospital, Kurla, and H.L. Doshi Hindu Sabha Trust Hospitals. After completing MBBS from Terna Medical College, Nerul, he did his MD in General Medicine from Rajendra Institute of Medical Sciences, Ranchi, Jharkhand, followed by DNB in Medical Oncology from Rajiv Gandhi Cancer Hospital and Research Center, Delhi. Dr. Maheshwari specializes in colorectal cancer and lung cancer. Dr. Maheshwari has acquired skills and hands-on experience and under renowned doctors during his training period. He has done various research works and projects and published numerous articles in journals. Today, Dr. Maheshwari will speak on modernity in the management of hematological malignancies. Thank you.
Thank you, sir. Thank you, sir, for the kind introduction. A very warm Sunday morning to everyone, and I hope we are in for a feast of lectures going ahead. So I would be discussing a very important topic here. Hematological disorders or malignancies, or related items which we see daily in and out in the clinic. So I think it's an important topic wherein we would understand what hemato-oncology will build an approach as we go, how to treat, how to see, and how to see patients and understand what all things can be possible, right? So it's just an approach building exercise rather than a didactic lecture, right? So now I'll want to ask everyone, most common abnormality that you see in a CBC, a complete hemogram, and for which we usually take an hematology opinion. Anyone from the public? Anyone? I cannot see anyone. Okay.
Leukocytosis?
Leukocytosis is one, absolutely. Anything else, sir? Anything else I would, which is slightly more commoner for a hematology opinion, right? So many a times leukocytosis will take a physician's opinion or a MD physician for infection and everything. A hemat opinion per se is for, I will just go ahead in the slide, is something that is our bread and butter, right? And that is called the platelet problem, and it is thrombocytopenia that we see, right? So thrombocytopenia is something which is not easily managed by people, and it's difficult where you need hematological opinion. So we are here and we see that, next, thrombocytopenia is the most commonest malignant problem that we see. How many patients we all see in our daily practice? Anyone? How many patients do we see in our practice? Anyone who can who sees a lot of thrombocytopenia in his practice, in his clinic? So I think it's a common common event wherein we see a lot of thrombocytopenia patients. Now suppose we have a case wherein we have a 45-year-old female with platelets of 45,000 per CU/mm, hemoglobin of 9.8, WBC of 5,500 CU per mm, and a normal differential count. What will you do? Anyone who would want to take this? There are 385 participants. I think let us be more interactive.
Sir, the delegates cannot join.
Okay, they cannot join.
They
Okay,
can
okay.
just put in
They
the
can
chat
just.
box.
So I will just be, continuously I'll be talking about the cases. And so we have this 45-year-old female, hemoglobin of 9.8, WBC of 5,500. And what is the next step that we do? Uh, so let us build an approach how we take these patients, into consideration. Now we'll go ahead with the basic history taking, wherein age, gender, blood loss, rashes, and history of weight, and history of fever, history of jaundice, and joint pain, weight loss. So beginning with age, a elderly gentleman with a thrombocytopenia versus a person who is younger, or a younger patient in the age of 20, 30, or 40s, will have different causes of thrombocytopenia. For example, a elderly gentleman of 70 plus year age would maybe have a leukemia, may have some myeloproliferative neoplasm, may have a myelodysplastic syndrome, while a younger patient like 30-year-old female may have a ITP or immune related side effects. So these are common ways where you can differentiate between age. Coming to the gender, as we all know that females are more prone to autoimmune disorders. So autoimmune causes of thrombocytopenias would be more commoner in female gender. History of blood loss, we'll have to ask, because if there is any past history of blood loss, we'll have to take that into consideration, that there is some blood loss that has happened and it is a recurring process. History of any rashes, so as to if the rashes are there, the platelet counts are mostly below 15 to 20,000. So we'll have to act fast, be feeted, and we'll have to uh, do a CBC with manual platelet count urgently, and then we'll have to treat them accordingly if the rashes are there. So always when we have rashes, you should always check for mucosal bleeding as well. If there is mucosal bleeding inside the oral mucosa, that also tells you that these rashes are they should be paid heed to. Now coming to the other history, that is history of fever. Any history of fever in the past will tell you that there was some viral etiology or a infective etiology that has caused a reactionary thrombocytopenia, and has that immune response uh, which increased for the infection, has also targeted our platelets. So it's an immune response towards fever targeting the platelets, leading to thrombocytopenia. Any history of jaundice? Anyone, why jaundice is important in thrombocytopenia? So jaundice is seen in vitamin B12 deficiencies, and vitamin B12 deficiencies also shows thrombocytopenia. So it gives you a important aspect as to how we can correlate the cause with thrombocytopenia. There is history of joint pain, there is history of weight loss. So joint pain, again, for any autoimmune disorders that we may see, there may be small joint pain, large joint pain, and we can discern the cause of thrombocytopenia from there. History of weight loss is important, as there are many malignancies where we see thrombocytopenia. If there is bone marrow involvement with any malignancy, that can lead to cytopenias, and obviously the thrombocytopenia will be associated with anemia as well as low WBC. So these histories are important to rule out single causes of thrombocytopenia, and these are the basic history that we should be able to understand what thrombocytopenia will lead to, right? So coming to post history, what should we check for in physical exam and lab test? So check for a rash, obviously, that I already discussed. There is ENT exam. Again, we saw that bleeding from nose, bleeding from mouth, any ear bleeding. So these are common bleeding sites that would give us an insight on whether there is any internal bleeding as well or anything else that is harming. Abdominal exam is also very important because we'll have to examine the abdomen to see for splenomegaly. Splenomegaly, the hepatomegaly, these are commonly present in patients with thrombocytopenia and should be seen and documented. Lastly, I would say that neurological examination is a very important aspect. Many a times in thrombocytopenia, we see minor bleedings in the brain parenchyma that lead to obtundation, slow drowsiness, forgetfulness, slight headache, and patient is conscious but he has some headache, some drowsiness which is new onset and has rashes. So we should be, it's a red flag sign. We should understand that these are neurological symptoms that are happening, and we'll have to support him with platelets, FFPs, and so on. So these are important examination points, laboratory examinations as well, and we'll have to take this into consideration. So what are the potential etiologies for thrombocytopenia? Now let us understand that most of the WBC, hemoglobin, and platelets are formed in the bone marrow, where the precursor cells or cell lines of these three cell lines are present. Now, considering that the bone or the bone marrow is a factory requires raw materials, and after the factory processes these raw materials, we get an output, right? So if we consider this as a factory, we will be able to understand the causes of thrombocytopenia better. So raw materials, if the raw materials are less, then what are the raw materials? Iron is a raw material. If iron is less, obviously the formation of hemoglobin is less. If minerals are less, obviously the formation of all the things, even the WBC, platelets, and hemoglobin is low. And lastly, vitamin B12, which forms a very important aspect, wherein B12 is low, and which leads to B12 is required for DNA as well as DNA formation. So if the DNA is not formed, then there are these cytopenias that happen with B12. So B12 deficiency classically tells us that there are cytopenias, there is bilirubin raised, and there is neurological obtundation. So these are three common symptoms. They appear in that order only. So initial deficiency will lead to thrombocytopenias or cytopenias. Then further, if there is deficiency of B12 for a longer period of time, you get LDH raised, bilirubin raised, and further, if it is further continued, the B12 on malnourished people continue for years, then they get neurological obtundation, which we don't see very commonly in clinical practice. So what we see is cytopenias, which is very common in B12 deficiency. So these are the aspects that we see when we consider the raw materials of it, right? So external factors that can affect the output. So now suppose we have seen the raw material part, that is prior to the factory part. So if the raw materials are deficient, what will the factory do, and what will anyone else can do? Now suppose if we take the other part, the factory is working well, but the output is not so good. Why is the output not so good? Are there some people who are sitting there and eating up the hemoglobin or the platelets or something? So yes, so that can be autoimmune disorder. There could be some autoimmune disorder wherein our own antibodies are killing the platelets, are killing the hemoglobin, or are killing the WBC. Secondly, it could be a viral infection wherein a immune response to the virus can kill the platelets. And thirdly, there could be platelet destruction or platelet consumption that could follow. So a platelet destruction or a platelet consumption, very common example is hypersplenism, wherein spleen is enlarged and it consumes the platelet. Second platelet consumptive disorder could be a DIC, wherein intravascular coagulation can lead to consumption of platelets across the body. So that can lead to thrombocytopenia. So these are very common causes of thrombocytopenia. Lastly, coming to the factory itself, can the factory be defective? Can the platelets come be low? Yes, there can be. So there are causes wherein the platelet formation is only low, and that is sometimes called aplastic anemia. There could be low megakaryocytes, there could be ITP wherein low megakaryocytes are present. So here we have less formation from the factory. There is some machinery defect inside, so we need to find all of that. So once we've ruled out the external factors, once we've ruled out the raw material deficiencies, if they are all normal, then we should go ahead and perform a bone marrow test and understand whether the factory is working in a proper shape or not. So coming to summing up, the thrombocytopenia causes are decreased production, increased destruction, and sequestration. So decreased production could be because of intoxication, viral infection, bone marrow infiltration with leukemia, tumors, radiation, drug-induced, nutritional deficiencies, and hereditary. And increased destruction would be immune thrombocytopenia, thrombotic microangiopathy, post-transfusion purpura, drug-induced DIC, and cardiopulmonary bypass. So these are the very common causes of thrombocytopenia that we see in daily routine. Again, just to highlight that when we practice in the community, we see these are the most common causes of thrombocytopenia, and these are the first that we rule out in any case of thrombocytopenia, right? So now enough of thrombocytopenia. Let us see the second most common reason for referring to a hematologist. So as sir had mentioned rightly, that leukocytosis is a very common reason, wherein if we rule out infection, what is the cause of leukocytosis? So that for that we do refer our patients to hematologists, and leukocytosis could be a plethora of four things, wherein lymphocytosis, neutrophilic leukocytosis, eosinophilic leukocytosis, and leukocytosis with left fold shift. So these could be 3-4 different aspects wherein we'll have to understand what is the leukocytosis composed of, and then we form our differentials or form our opinion as to what it could be. So most common causes of leukocytosis would be infection, chronic lymphoproliferative disorders, chronic myeloproliferative disorders, which includes CML, which we see commonly, essential thrombocytosis, CMML, and polycythemia vera. Acute leukemia also is one of the factors when leukocytosis is common, and lastly, a leukemoid reaction. So these are a very grossly common causes of leukocytosis that we see. Now, what to do in these patients, right? How do we build an approach? First and foremost is to rule out infection. Obviously, any leukocytosis patient with a history of fever, with sepsis, symptoms of sepsis, with the toxic look that he has, if all of that is there, then obviously infection becomes our first malaria, TB, all the tropical infections should be ruled out. And to rule out and other reactive causes of leukocytosis, to rule out any atypical cells in peripheral smear, leukemia, how to diagnose? Flow cytometry is the most common way how we diagnose a leukemia. And for CMPN and CLPD, molecular tests, cytogenetics, and FISH. Right, so these are the this is an approach building wherein we understand that infection is ruled out. There are other reactive causes of leukocytosis are ruled out. Then we see for atypical cells in the smear. If there are any atypical cells, then we look at leukemia and CMPN, and we do a flow cytometry, molecular tests, and cytogenetics to understand and decipher whether it is a leukemia or what type of leukemia, whether it is a chronic myeloproliferative neoplasm or a chronic lymphoproliferative neoplasm. So these things we'll have to understand. Now coming to what is a chronic myeloproliferative, this is a very, very common aspect where we see that most family physicians and or other doctors as well would want to give, the leukocytosis, and the patient has taken, even we as physicians initially we treat these leukocytosis with antibiotics, and most of the patients that I see have taken an antibiotic for a year or so, and multiple antibiotics over the past year, and it's come to me that, whatever we do, the counts are not coming down, and they are high, and everywhere I go they say that it's high infection, 45,000 counts WBC, you should be admitted in a hospital, you should be in a facility with higher antibiotics ongoing. And these patients usually I counsel that, it may not be anything, because clinically you don't seem sick, you don't have any symptoms of a leukocytosis with infection. So stay calm, stay put. We'll just do some blood tests, and we'll, diagnose and give that name to your disease, and then no longer we'll have to take antibiotics and basic over the counter antibiotics, right? So these will have, patients will have a very long history of leukocytosis that I mentioned, and use of multiple antibiotics over a period of time. Most common tests that we prescribe in these patients is where we understand that this leukocytosis is not associated with infection. We do a procalcitonin, we do a CRP, we do all of those tests which which are suspected in infections. And if those are negative, then we do the tests which are pertinent to CMPN, and mostly a serum erythropoietin level, a JAK2 mutation testing, a BCR-ABL translocation testing. These are the testing which tell us which are the most common mutations seen in CMPN. And majorly, if it does not bother, it does not require treatment as well. So if CMPN or a CLPD does not require any treatment, does not bother us, will not require any treatment, they will just be on observation. A patient with 45,000 counts will require only a uh, 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 will require just observation and nothing else, right? So coming to a case, 68-year-old male presented with the following CBC findings: HB of 12, platelets of 6 lakhs per CUMM, and WBC of 25,000 per CUMM. Then differential counts looks like this. It's almost normal, right? So the patient, now two things that are important: is the patient sick? No, the patient is not sick. Is the patient having history of leukocytosis? Yes, I checked the reports of last 1 year. There are multiple CBCs showing a WBC count of 25,000, 28,000, 30,000, 34,000, 18,000. So that has been the trend throughout the year. And how many times has he been admitted? He may not be admitted for more than 2 to 3 times. So that history is very important, whether he was sick, whether he was admitted, whether his past CBCs also show the same thing. So that is what I'll do. I'll check all of these tests, all of these history, and understand that this 68-year-old gentleman does not have anything. He just has a WBC count raised, for which we have been treating him, right? So history, labs, serum procalcitonin, CRP, ESR would be important. We would also, at 68-year-old, we would want to, cancer is, age is the most common cause for blood cancer. We would want a good peripheral smear examination, which will grossly rule out cancers. And that is how we proceed with these patients. Lastly, if we understand that these are all normal, then we'll have to do these JAK2, BCR-ABL mutation, CALR, and MPL tests for chronic myeloproliferative neoplasms, right? So that is how we treat these leukocytosis patients. Last case where I'd be discussing a patient with hemoglobin of 19 gram per DL. How many of us have seen a hemoglobin of 20, 21, 22? Anyone? So I think it's a common case wherein hemoglobin, a high hemoglobin is seen very commonly, and even platelets for that matter are to the tune of 13 lakhs per CUMM. So what do you think we should do? Patient also has thrombocytosis, as we saw. The causes of polycythemia, a hemoglobin in male of about more than 17 and female of about more than 16 is the defining criteria for polycythemia. Polycythemia could have various etiologies: smoking, Living at high altitude athletes and polycythemia vera accounts for the most common causes of polycythemia. So what do we do in such cases? We'll have to understand that we need to do an erythropoietin level. Smoking high altitude athletes will have high erythropoietin levels, which is the cause for polycythemia. Erythropoietin is a stimulator for hemoglobin formation. If that is high, the hemoglobin may be high. However, polycythemia vera, the erythropoietin levels would be very low. So if a low erythropoietin level, but there is some mechanism by which the hemoglobin is continuously forming and increasing, is what we test with the JAK2 mutation, BCR-ABL, CALR, and MPL mutation testing. So if these 4 mutation testings are positive, or there are many other mutations also, but then those account for only less than 2% of the cases. If these are positive, then we know that this polycythemia is a part of chronic myeloproliferative neoplasm. That is how we diagnose these polycythemia patients. So let us sum it up now. We'll just conclude with thrombocytopenia is a very common issue in clinical practice. Most common causes of thrombocytopenia are vitamin B12 deficiency and viral infection. I would like to mention here very important point, that it is very imperative to do vitamin B12 test prior to giving supplements at baseline. So most of the patients that I go to see a reference, or I go to see a patient with thrombocytopenia or a cytopenias, have already been started on vitamin B12 without sending a B12 test. So if they have been started on B12, I cannot do a B12 test and the diagnosis is still eluded. So we should do, even before starting a B12, we should do a B12 test for these patients and then start B12. That is okay. Starting B12 is not a problem. We should definitely do a test prior, right? Secondly, leukocytosis does not always mean infection. Yes, it is the most common cause, but if it's not improving with antibiotics, we should think of rather CMPN, that is chronic myeloproliferative neoplasm, and a chronic lymphoproliferative disorders that are common causes in non-infectious leukocytosis. It may be possible that these patients may not require treatment in their entire lifetimes, and they just maintain their WBC count at 20, 30, 40,000 throughout their life and nothing happens. So I would like to close in with these words: the eye does not see what a mind does not know. So I think we as physicians should understand that these are important aspects we see daily in and out in our clinical practice, and we should have the eyes and the mind open for these. Thank you so much.
Thank you, Dr. Maheshwari, for the wonderful lecture, and you have explained it very nicely in very simple language. Any questions?
There are no
From
questions
the
in the
panelists?
question box.
No questions.
Any questions from the panelists? So on thrombocytopenia, I would just like to ask, some patients have a chronic low platelet count. They are always around 1 and below 1. Yes. And no matter whatever we give them, they go up and again they come down. So what is that sort of idiopathic thrombocytopenia?
Sir, it is there are no reason for that. I have seen so many patients, and then they are harrowed every day. They come,
yes,
harrowed कि यार मेरा प्लेटलेट ही नहीं बढ़ रहा है.
हाँ, they are so worried.
बोलता हूँ कि सर पैसे नहीं है, पैसे बढ़ेंगे तो अच्छी बात है, प्लेटलेट नहीं बढ़े तो भी चलेगा.
उनको लगता है कि उनके बॉडी में डेंगू वायरस बैठा है.
Yes, so this is very common, sir. It is unfortunate that we've not been able to find a proper reason for that. But there are some patients who have low platelets. I have at least 10 to 15 patients who have platelets of 80, 85, 90,000.
Yes, yeah, even I have a couple of them.
3-4 years. Yes. And they are maintained like that. So now they know that doctor A bolega कि पैसे नहीं है बढ़ेगा नहीं. So now they don't bother to ask. 80 है खुश है. That is, they are happy with that.
They want to eat all that papita and all that tablets and then all that fruits and then.
We should let them eat, sir. At least they'll eat some healthy food.
So otherwise they are always stable. Nothing happens to
Absolutely,
them.
nothing happens. So platelets, whatever platelets is required for us, even a major surgery can be done at 50 plus platelets. So we are
Okay.
not worried when the platelets are less than 50 or 50 plus. And if these have to be followed up, if the platelets go below 50, then we do extensive examinations. We do NGS testing and find out the reason for that. There can be
Right.
sometimes some hidden mutations that we cannot find. We can find it in the next generation sequencing. But
Right.
then those are expensive tests, 50,000 tests for a thrombocytopenia. I don't think it validates those.
So if these patients land up with a dengue infection, would they fare
Absolutely.
badly or
They will be prone to more thrombocytopenia.
okay?
So we'll have to be very cautious, give steroids early, let the viral infection not cause. So that is what I tell my patients, that any viral infection, do get a CBC done fast, because you are prone to thrombocytopenia.
Mm-hmm. Very true. Yeah. Are you going to follow? I mean, continue with the second lecture, or
No, I'll do it
we are
after.
getting different orders of lectures? Just now.
Sir, I'll get it. I'll do the second lecture after this, after one more.
After.
So
Acha, okay.
someone can do the first.
Okay. Then I think Dr.
Yeah.
Seema is going to
Yeah,
say.
No, not Seema, Divya Udyavar.
No.
Yeah.
Okay, Dr. Seema, Dr. Divya. Which one of you will be talking?
So now Dr. Divya will talk.
Okay. Okay.
We go to the next speaker for today's webinar, Ms. Divya Udyavar. Dr. Divya Udyavar is an eminent genetic counselor at Mumbai ONCOLOGY Center, Camps Corner. She has completed her Bachelor's of Engineering in Biotechnology from Thadumal Sahni Engineering College, Mumbai, and Master's in Science in Genetic Counseling from Kasturba Medical College, Manipal. Dr. Udyavar has also worked in Tata Memorial Hospital as a volunteer genetic counselor and in New Horizons Child Development Center as a trainee genetic counselor. She has a rich experience in conducting pre-test and post-test counseling sessions and psychological counseling. Her areas of interest are psychological counseling, cancer genetic counseling, prenatal genetic counseling, reproductive genetic counseling, and cytogene and molecular diagnostics. Dr. Udyavar has presented multiple papers in national and international conferences and has several publications in peer-reviewed journals to her credit. Today, she'll be speaking on genomics and familial cancers. Over to Dr. Divya Udyavar.
Hello, everybody. Good morning. Thank you for the wonderful introduction. Just give me one moment to present my screen. I hope my screen is visible.
Yes. Yes.
Okay, great. So as the topic for today goes, it's genomics and familial cancers. Although I'll be presenting it from a different perspective, where we will cover the topic mentioned too, with the perspective wherein how a genetic counselor can be involved and can help out oncologists in diagnosing hereditary cancers, familial cancers, and how genomics would be involved in this bit, and what role it plays and how it's involved, how it makes an impact on the life of the patient. So whenever I mention to people around that I am a genetic counselor, the general there'll be some magical mantras which would be said, and then boom, you'll have the risk for the patient. Although if it was that easy, we would have been the happiest person on earth. Though the process is very, very elaborate, it has 3 steps mainly. There is pre-test genetic counseling, wherein we take a detailed family history, draw a pedigree of the family, along with the general medical history of the patient, when we try to understand what is the nature of the cancer, what is the age of onset at which the patient has got the cancer, the age of onsets for the other family members who would have been cancer affected. All these are minute details which are very, very important and are taken into consideration. Based on the pattern of the pedigree, and based on how much we feel that this particular case is leaning towards the hereditary aspect, we order a genetic test. Again, genetic tests, as you all know, today genetics is emerging at a very high speed, and you have multiple tests available. So to understand which test exactly is going to be suited for this particular family and how cost effective it is going to be, based on that we decide which is the best suited test which needs to be sent. And then we have the results which come out. Genetic test reports results can be a little difficult to interpret, so there is an exact interpretation required, in which the genetic counselor can again help. And post the interpretation, in case there are any kind of pathogenic variants or mutations which have been identified in particular genes, we give them a management plan. So that's what forms the post-test counseling. So mainly you have three steps. There is pre-test counseling, genetic testing, and then there is post-test counseling. So this is a spectrum which shows us how cancers can be classified. If you see that there is a huge chunk of 80% which forms this sporadic bit. The sporadic bit is wherein there has been no family history which has been associated earlier. There is no genetic basis for so basically no hereditary basis for the cancer that we have found out. And the patient seems to be a one-off case of cancer, the first case to be diagnosed in the family. So most individuals that enter oncologist clinic would fall into this criteria. Basically, again, if you go to see, most of them would either have a lifestyle associated cancer, or they would be in their older ages, or maybe they would have something that we call the population risk associated. A very good example is the female breast cancer. So a lot of females walk in with no family history, no basis at all. So those are the cases that we'll classify into the sporadic chunk. Then you see this can be a little confusing, wherein why familial and hereditary has been termed as different, because we generally tend to confuse between the two of them. Yes, they are very different from each other. How different, I'll be elaborating on that in the next slide. Although what you need to understand here is familial is what forms 10 to 15% of the chunk, and the most important chunk which forms the least but requires the most attention is the hereditary chunk, which forms only 5 to 10%, although these are the ones which need the most follow-ups and the most strict kind of surveillance that needs to be given to them. So we'll be discussing in detail as to why is this so. So firstly, helping you distinguish between these two, familial and hereditary. So familial is a cluster of similar cancers in a family. They might not be due to an inherited genetic change, and it could be an event of chance. So what I mean by an event of chance is maybe if two individuals in the family have got breast cancer, but if they've got it at say 60 and 65 years of age, then maybe there is no correlation, there is no genetic correlation that we can derive between them. It is just by chance that because this is female breast cancer is so common in the Indian population, by chance two people in the same family have happened to get the same disease. So a cluster of similar cancers. Again, I have a pedigree in the next slide, which will help you understand it better. On the contrary, you have hereditary, which is caused due to a common inherited genetic mutation. So all the affected individuals in the family, if you actually do a genetic testing on them, you'll be able to find out one single cause, one single mutation, which is causing the cancer in them. So basically, this is a direct correlation, and it helps us delineate that the case is a case of hereditary cancer. Also, the pattern of cancers would be very, very recognizable. You'll have a better idea of it with these pedigrees. So first we'll look at the familial cancer pedigree. If you see, there are 4 individuals in the family, 4 females in the family who've been diagnosed with breast cancer. So like I mentioned, cluster of similar cancers you can see here. Although the ages of onset, if you see, we do not have the age of onset for one of them, though 3 people whose ages of onset are known are at very late ages, what we consider. So it's post 50. So breast cancer post 50 is generally generally classified into the population risk category only. It's not very early onset. And like in hereditary, I mentioned there's a recognizable pattern. If you see very closely, there is no recognizable pattern here. So the 52-year-old who got the breast cancer, although her maternal aunt and her maternal grandmother got the cancer, her mother is still healthy. So her mother did not get the cancer. Again, there's the grandmother, and only one of her daughters has got the cancer. The other daughter who's healthy, her daughter has got the cancer. There's another daughter who's healthy, and her daughter's got the cancer. So it's not very recognizable. I wouldn't say that, such kind of pedigrees would not show up in hereditary cases, because every hereditary case, to be honest, is very different from the others, and it can actually surprise us a lot of times. But it's very rare that you'll have such an unrecognized pattern in hereditary cancers. So if you look at the pedigree below, you'll be able to see that the pattern here is very, very recognizable. So the 38-year-old has got the cancer. Her mother also had the cancer. Her grandmother also had the cancer. One of her aunts had the cancer. Aunt's daughter also has the cancer. So you can see that anybody who's got the cancer has passed it on to the next generation, and the next generation has also got the cancer. Plus, another thing to be noted here is most cancers are early onset. You have somebody as young as 33 years having a breast cancer, somebody as young as 38 years having a breast cancer. So the ages of onset, like I mentioned, in hereditary, there'll be very early onset ages. Plus, you'll have a very recognizable pattern. And then if we do a genetic test for these people, most probably we should be able to identify one single mutation in a single gene, which is common for all these individuals. And that's what's causing the cancers in the family. So what are generally anything, nowadays you have so much of genetic testing coming up that every other day you have a new gene being discovered associated to hereditary cancers. And also hereditary cancers are not just, you can't term breast cancer as an hereditary cancer in itself, because it will generally be caused by a gene, and the gene would generally be associated to other organs as well. So because there is a multiple organ involvement here, it's generally termed as a hereditary cancer syndrome. So till date, we have more than 50 hereditary cancer syndromes which have been described. Pathogenic genetic variations in the tumor suppressor genes, or the DNA repair genes, or the mismatch repair genes. The tumor suppressor genes, a very good example is BRCA1 and 2 that we'll be discussing in detail in the upcoming slides. DNA repair and mismatch repair genes is the Lynch syndrome, if you've heard of. It is a group of genes. The mismatch repair genes are a group of genes which cause the Lynch syndrome, and a defect in them basically puts an individual at a high risk of colorectal and uterus cancer. Mostly, these hereditary cancer syndromes are autosomal dominant in nature. So going back to your medical MBBS days, you must have studied about autosomal dominant, autosomal recessive. So autosomal dominant is wherein a single copy of the gene is, even if it is defected, it is enough to cause the condition. So you don't need 2 copies of the gene to be defected. Even if one of the copies of the gene is defected, you are prone to get the condition. And there is an incomplete penetrance which is seen. So incomplete penetrance is something which is a very characteristic feature of most hereditary cancer syndromes. That is why each one of them can be surprising, is what I mentioned in the earlier slides. What we mean by incomplete penetrance is basically, even if the mother has the genetic defect and she's passed it on to the daughter, we cannot always be assured that the daughter is definitely going to get the cancer. So, for example, if a mother who is 75 years of age, she was diagnosed with a breast cancer, say at 40 years of age, we tested her and she tested positive for the BRCA mutation. And now she has, say, 4 daughters, out of which for 2 of them, she's passed on the mutation. One of the daughters has got the cancer, but another daughter is almost close, nearing her, say 50s now, but she's yet not got the cancer. So we cannot predict that she'll definitely get a cancer in the years to come. So that is what we mean by incomplete penetrance, that even though she has the genetic mutation, we cannot always be assured that she will definitely get the cancer. She might pass the cancer, she might pass the mutation, but she might be completely healthy. So that does happen. You do not always see expression of the mutation in the individual, and that is why we term it as incomplete penetrance. So, like I mentioned, there are over 50 hereditary cancer syndromes, but I've shortlisted 5 for you, which are very important and need to be on the top of your mind. 4 for you, ideally, which are very important and need to be on the top of your mind. It's the hereditary breast and ovarian cancer syndrome, the Lynch syndrome, the Li-Fraumeni syndrome, and the familial adenomatous polyposis syndrome. So we'll be going into much depth of each of these, talking about the most popular hereditary cancer syndrome that I think most of you would almost know 75% of what I would be talking. I'll be happy to contribute the 25% if at all I'm able to. So the major genes which are involved here are the BRCA. The BR in the BRCA gene stands for breast, CA stands for cancer. So it means breast cancer susceptibility gene. So you have 2 of these breast cancer susceptibility genes. You have BRCA1 and BRCA2, BRCA1 on chromosome 17 and BRCA2 on chromosome 13. So who exactly do you have to suspect for a BRCA test, or who do you consider to be a part of the hereditary breast and ovarian cancer syndrome? Any individual, any female who's been diagnosed with breast cancer at or before 50 years of age. If you have ovarian cancer at any age, this is precisely because there are huge treatment benefits that the patient can derive out of the BRCA test. So no matter at what age an individual walks in with ovarian cancer, a BRCA test should be mandatory. Multiple primary breast cancers, either in one or both breasts. If you have a male breast cancer, very, very rare, we all know. So any case of male breast cancer, a genetic testing for BRCA1 and 2 should definitely be sent out. A triple negative breast cancer, particularly when it's diagnosed before the age of 60 years, or if you have a combination of, say, pancreatic and or prostate cancer with breast cancer and or ovarian cancer, that kind of combinations, if you see in a single individual, then you need to again send out a genetic testing. And of course, if there is a family history in which one or multiple first or second degree relatives have been diagnosed with one of these cancers. So if that kind of a history is present, then we definitely need to send out a genetic testing for the BRCA1 and BRCA2 genes. So here is how the genetic testing is going to make a difference to the family. If there is a risk of malignancy in one of the BRCA1 or 2 genes, you can see how drastically the numbers are changing, the risk figures are changing. A breast cancer risk, which is 12% in the general population, goes up to almost 87% in BRCA1 and goes up to 84% in BRCA2. Similarly, the other cancers, you can see ovarian shooting up from 1 to 2 to 63% when it comes to BRCA1. You can also see that when BRCA2 is involved, although the risk figures are less, but you have some more cancers which are being added up. So there's pancreatic melanoma, which is added up for BRCA2. The risk, we need to give a management plan to the patient for these cancers as well. Whereas in BRCA2, these don't really play a very big role. So we needn't give a management plan keeping them in mind. So how do we do a clinical management for an individual who's been diagnosed with the HBOC syndrome? So for women, we have the breast cancer screening, wherein there's a monthly self-breast examination, 6-monthly clinical breast examination, and an annual breast MRI, which is advised. For ovarian cancer, there are screening options available, which can be a transvaginal USG and CA125. Although for ovarian cancer specifically, if they fall into the risk criteria, we generally emphasize on the fact of getting a risk reducing surgery done. So this is going to be of utmost benefit to the individual, because we know that ovarian cancer screening is not very sensitive, and even if there is a tumor which has been growing inside the individual will not really be, we cannot always be assured that we'll be able to pick it up through these screening methodologies. So that's when we kind of strongly advise and emphasize that they definitely need to consider the option of a risk reducing surgery. Of course, keeping other social, cultural, family dynamics, all of this into consideration, because if somebody's not yet planned on their family, that's going to be their priority, and they need to start taking decisions in that direction. So management plan, as you can see, will not just be related to the clinical management, but there are so many other aspects which are going to be involved. Again, when there are these other aspects involved, there are going to be a lot of psychosocial issues that the individuals are going to face, and that's where genetic counseling plays an important role. So for men, you have breast cancer screening. Firstly, it's important to make them aware about it, giving them education, telling them that there is actually something known as male breast cancer, and training them as to how they can examine, and an annual clinical breast examination, and then you have a prostate cancer screening. So one point which I've missed here is basically, just like you have a surgery for the ovary, you also have a prophylactic surgery which can be done for the breast as well. In case an individual does not want to undergo routine screening, we can also discuss the option of risk reducing surgery for the breast with them. Moving on to the next important syndrome that we partially discussed, the genes which are involved, the mismatch repair genes. So the mismatch repair genes are basically the genes which have been enlisted here: MLH1, MSH2, MSH6, or PMS2. They, if there is any defect in them, it causes the Lynch syndrome, which was earlier also known as HNPCC. So HNPCC is not used now, because it was basically called the hereditary non-polyposis colorectal cancer syndrome. But the name did not do justice, because as you can see, there are so many other cancers also involved other than colorectal cancers. So that's why the name was changed to Lynch syndrome. So herein, an individual can have an increased risk for colorectal cancers, cancers of the endometrium, stomach, ovary, small bowel, hepatobiliary tract, urinary tract, and less likely sometimes also in the skin. So a huge list will always be presented in any of the hereditary cancer syndromes, but given below are some of the important risk figures which we need to keep in mind. So major focus on colorectal cancers, endometrial cancers, gastric cancers, and ovarian cancers. Ovarian cancers also, you can see the figures are quite less in comparison to BRCA 1 and 2, although because ovarian cancer is kind of common than the other cancers that we've seen, so it is important to kind of throw light on it. One of the most underrated, yet one of the most, I would say, one of the most critical hereditary cancer syndromes is the Lee-Fromeny syndrome, which is caused because of a defect in the TP53 gene. Although it has not gained as much traction as the hereditary breast and ovarian cancer syndrome, because BRCA 1 and 2, as you know, after the Jolie effect, there was a boom, and there was a lot of awareness about this hereditary cancer syndrome. Although Lee-Fromeny syndrome, I think, requires as much recognition because of the wide spectrum that it involves. Basically, you can see in point number 3, there are so many cancers listed, as many cancers as you can think of. The Lee-Fromeny syndrome can basically cause any kind of cancers that we know. That's precisely because the TP53 gene is generally known as the guardian of the genome. So you can imagine, if there is a defect in the guardian of the genome, then the genome is definitely going to be a mess, and you can expect any and every kind of cancer to be involved in this particular syndrome. That's one reason. Another reason being, the age of onsets can be really early. So you have both childhood and adult onset malignancies here. You generally, that becomes a very difficult spectrum to deal with, wherein you have children who are at risk of so many cancers. So of course, if you have so many cancers enlisted, the screening protocol is going to be as aggressive, and that becomes a very, very difficult issue to deal with, to explain the family about it, to explain the family to get the testing done for the children, to get the children to follow the screening protocol is generally a very difficult issue that we face with respect to the Lee-Fromeny syndrome. Next up is the familial adenomatous polyposis syndrome, which is FAP. It is very similar to the Lynch syndrome, although there's a very high risk for colorectal cancers. But how it is differentiated is basically in the FAP syndrome, you will have multiple adenomatous colonic polyps that you will see in the individual's colon. So generally, the figures are above 100 that we consider. So they can have multiple colonic polyps, and most the histopath of these polyps would be adenomas. And the average age of onset is also particularly less in comparison to the first two syndromes that we discussed about. It can generally be at 16 years of age. There's an average 7 to 36 years, which is mentioned. Also, they can have extracolonic manifestations. This is something that most people do not know about. They just advise a colonoscopy and check out the polyps and come up to the diagnosis of FAP. Although there are certain other manifestations that they can have, which can serve as an evidence to basically confirm if they actually fall into the FAP criteria. One of the most common investigations that we can send out for an individual who's suspected for an FAP is the CHRPE test, CHRPE. You can see there. It's basically an eye evaluation which can help us confirm the diagnosis for clinical diagnosis for FAP. Of course, to confirm the diagnosis, we need a genetic test. So based on these two evidences, the colonic polyps and the CHRPE test, we can send out the genetic testing for the APCG. So we discussed about all these hereditary cancer syndromes and so much of genetic testing that we spoke about. But how exactly is genetic testing and genetic counseling helping individuals around? So I have bifurcated it into healthy and affected individuals for you to understand better as to how genetic counseling can exactly help these individuals. For the affected individuals, there are treatment decision making which can be done. Of course, we saw in BRCA 1 and 2, I mentioned for ovarian cancer, there are very important treatment decisions which can be taken based on their BRCA status. Similarly, there is a selection of treatment strategies. Which treatment strategy is exactly going to be the most beneficial for the individual, which can be figured out from the genetic test. Prevention or early detection of cancers in the future. So if an individual has already been diagnosed with a cancer and they've gone through the whole tedious process of treatment, we're sure they don't want to, the family or the individual doesn't want to fall into this particular phase again. So we put them into an early detection phase with all the strict screening protocols that we're giving them, and also the preventive surgeries that we discussed about. That puts them into a phase of absolute prevention of the cancers in the future. There is predictive testing that we can do for the family members. A mother who has been diagnosed with a BRCA mutation, the next concern that she's going to have is if my children are going to get it. So we can definitely get her children tested. There's a 50% chance that they would have also inherited the mutation. In case they have inherited the mutation, we can put them onto an early detection plan again. We can discuss the preventive options with them. That basically keeps them well equipped about what comes in the future, and they can accordingly take all kinds of decisions in life based on that. So that relieves the mother that at least my children know about the risk and they're taking steps so as to prevent cancers in the future. For healthy individuals, as we discussed partially in the last segment, that there is surveillance for early detection, which can be done. Prophylactic surgeries, we can discuss the option of prophylactic surgeries with them. And also there are some chemopreventive measures which we can discuss with them, wherein even in the future, if they ever require chemotherapy, some other options which can be available for them can be discussed with them. So, meanwhile, when we discussed all of this, I'm sure you would have understood that it's not just one individual that gets diagnosed with a hereditary cancer syndrome. It's the entire family who gets diagnosed with that particular cancer syndrome. And it's not just relevant clinically to that particular individual or that particular family, but there is so many other aspects which are involved: the financial aspect, the social aspect, uh, how do they discuss it with their extended family, are there any changes which are coming in the family dynamics because of this particular diagnosis. So that follows a lot of psychosocial issues that they can come across, and these psychosocial issues would generally be very difficult for them to discuss upfront with somebody who would not know in and out about the genetic cancer syndrome. So herein genetic counseling plays a very important role, because the genetic counselor can help them and help them normalize the process, help them connect with other individuals, other families maybe, to understand what are the different coping mechanisms they can take up, what are the strategies which they can take up to get more to accept the diagnosis particularly, and how other issues that they have been facing can be dealt by just talking and being counseled. So that's all for today. Thank you very much. I hope in the brief time that I had, I was able to throw light on how genetics, familial hereditary cancers, and genetic counseling helps in the process. Thank you. Hello.
Thank you, Ms. Divya Udavar, for the nice lecture. We have one question here. Is there any role, why this came? Is there any role of apoptosis regulatory genes in the pathogenicity of breast cancer?
Today's discussion was all about the germline mutations generally, which are involved in causing breast cancer genes. So the ones which are generally related to apoptosis or any kind of cell pathways that we know about are generally involved on a somatic basis, basically in helping the tumor grow, or in helping changing the dynamics of the tumor. So that will generally fall in the somatic aspect, and that's why it wouldn't really be related to what we discussed today. So we wouldn't be able to derive a direct correlation between these genes which are involved in apoptosis with breast cancers, which would generally be hereditary in nature.
Okay, thank you very much.
So I have a question.
Yes.
Practical question. Patients come to us, elderly people or middle-aged, they want to get a full screening done just to see if they have got any dangers of future cancers, or so how there are a lot of panels available of testing. So how do we decide, and what are the criteria for this?
So firstly, sir, I would like to emphasize on the fact that, we generally do not send out tests for any healthy individuals, no matter what their age is. That's particularly because genetic information tests that you've done on the DNA can generate really enormous and, overwhelming kind of data, which is very difficult to interpret. So until and unless we have a clinical evidence, we have a clinical reason for why we're getting a particular individual tested, we cannot generally run a hereditary cancer panel or any kind of genetic test on healthy individuals. So basically, if you have such individuals coming in with a request for any kind of genetic panels that they want to run, I think you can explain to them as to how these tests, instead of being beneficial, would actually add up to their anxiety, because the data which would be generated, since there's no clinical correlation to it, we wouldn't generally find an answer, and it will leave us in a gray space, which we call as a variant of uncertain significance, basically, wherein we cannot term whether this particular variant is pathogenic, something which is damaging, or it is something which is normal. So rather than getting into the spectrum of genetic testing, we can basically advise these individuals to take up general cancer screenings based on the evidences that we have for the population, based on the evidences that we have for gender specific evidence at their particular age. So a female who's 60, maybe we can advise her to get the breast cancer screening done primarily, because we know that breast cancers are so common in the Indian female population at that particular age, especially. So we should stick to the general cancer screening for these
Marker,
individuals rather than a genetic test.
Correct. Yeah.
Okay, thank you.
Thank you. Thank you very much.
Thank you. Now we move on to our third lecture. Now, Dr. Maheshwari will continue on clinical pearls in cancer care. Over to Dr. Maheshwari.
Dr. Maniar is.
Yeah. Yeah. So, yeah, sir. Please, you can mention that.
Yeah. So Dr. Maniar, he was supposed to talk on this subject, but since he's not able to make it on the screen, I think Dr. Udip will do the needful.
Thank you, sir. Thank you so much for clarifying. And if there are any oops moment in the PPT, then please be sure, be certain that this is the last moment thing that we have changed. And I'll try and do justice to Dr. Mania's presentation. He is an excellent speaker, so I would want to do justice to his presentation, right? So let's begin. I think it's a very common, it's a very pertinent topic in the current scenario. I hope everyone can hear me. So it's a very pertinent topic in this scenario. The holy grail in cancer diagnosis. Let's brainstorm. So these are cases wherein what we tend to do is not generally what we need to do or what we would have liked to do, right? So these are those cases. It's purely a case-based discussion, right? So let us go ahead and see what is a holy grail, something that you want very much, but then that is very hard to get or achieve. The cup that is said to have been used by Jesus Christ and that was sought by knights during the Middle Ages. So the diagnosis of cancer or how we go and approach those patients wherein we are suspecting cancer, and how to get the right decision making into the diagnosis is what we want to achieve, which is very difficult and comes with a lot of efforts and hard work. So we have just summed up few cases so that we can give a gist of it. So what are the the cancer diagnosis associated with anxiety, apprehension to the patient and the family? That is very important. Most patients who come to us are anxious, and their family, they've not slept the whole night. The next day they're waiting for your appointment, and they come, they sit, and that whole period, that those 24 hours are full of anxiety, full of apprehension. And then when they come to us, we make sure that these anxiety and apprehensions are at least are when they leave our OPD room, at least they are catered to, and they feel relaxed post going from our OPD. So that is something that is very important, that these patients are very anxious and very apprehended, and we should be very cautious of what we tell them, how we tell them, what positivity we can give them is something very important, right? So there is no single predictive test also that is also adds to the anxiety of the doctors as well as the family physicians as well as the relatives, because you cannot you cannot say that this guy will get cancer in the next 5 years. There's no test to do that. No single definitive test to diagnose cancer as well. So once you, if you're suspecting cancer, is there any single test? Yeah, aaj ye kar lo, that is it. And you will be diagnosed and you'll be solved of all the queries, all the anxiety with this one single test. No, it's not that. So that is why we have to build an approach and understand how all of these different tumors needs to be diagnosed. Is biopsy mandatory for all lesions? We'll go ahead and see. Is biopsy mandatory? Not all the tumors that we see are supposed to be biopsied, or they require biopsy. Let me put it in a better way. Not every tumor will require a biopsy. However, wherever we need to do it, we should do it, because it's the basic thing for starting our treatment. Now coming to the first case, a 31-year-old female, 4 weeks postpartum, noticed the lump in the breast during breastfeeding. 4 into 3 centimeter tender lump in the right upper quadrant. Skin over the lump is inflamed, and the chap sees on Google, says that it's a stage 3 breast cancer, puree orange appearance, and the whole family is panicking. This happens at 9 p.m., 9 to 9:30 p.m. And Dr. Desai from Kulaba gets a frantic call on Saturday evening that, I have a breast lump and it is breast cancer. Google says that it is breast cancer and it is stage 3. What do I do? So what should Dr. Desai do? I think because had it been interactive, we would have loved to take the responses, but I would go ahead and describe few of the responses that everyone gives. So what should Dr. Desai sir do? So basically what happens is, she is a postpartum female. She has been breastfeeding and she has a tender lump, and that is painful and is felt. But then what Google says is cancer. But are any tender lumps cancer? So most of the tender lumps will not be cancerous, that is for sure. Either they could be infectious, they could be a retention, like a milk retention cysts, or they could be anything benign that can cause pain in the breast. It could be a breast abscess, it could be anything that can lead to a painful lump in the breast. So there are differentials for painful lump in the breast, and it may not necessarily be a cancer situation. So what sir should do is to calm them that this, in your age and in the setting that you are in, does not appear to be a cancer. You come visit me tomorrow, and then we will take a call on what should be done next, right? So this is that. Coming to the second case, a 48-year-old male, fatigability since last few weeks, investigated, found to have a blood loss anemia. A CT abdomen plus pelvis was ordered. It shows a 2 into 2 centimeter lesion in segment 4, another 2 into 1 centimeter lesion in segment 5. Are they malignant? The patient automatically calls up his own radiologist, the person that is done an x-ray of his wife from, and he calls him and says that let us get a CT scan done or a CT biopsy done, because this lump is showing this. And then he calls, in this process he calls Dr. Kale and asks for his advice. And it's a Saturday evening. Dr. Kale would have wanted to go to a movie with the family. What does Dr. Kale do? Is it a very urgent setting, or what let us help Dr. Kale decide? So according to me, these are not some things that would require a biopsy. So what we described initially, that is a biopsy required? Yes. Fatigability since 4 weeks is there, blood loss and anemia is there. These are red flag signs. Obviously we should act on it and on urgent basis. But a CT biopsy, is it required? It is not required in a suspected liver cancer patients. We will need to do a triple phase CT scan and understand the nature of the lesion. A triple phase CT scans does contrast is given in delayed venous phases as well, and then we see what are the arterial enhancements and what are the venous washouts in the CT scan, and that characteristics can give us an idea as to what it is. So I think we should do a triple phase CT scan, which is important, and that will help us give the diagnosis. And let's not jump to biopsy very soon. So that is what I wanted to discuss. Okay, so case 3 now, coming to a 54-year-old male, hepatitis C positive cirrhotic since 10 years, on strict follow-up with his gastroenterologist. He's been following up with his gastroenterologist for last 10 years and forgotten that he has a family physician of his, and he has been on gastroenterologist opinion ever since. Recent investigations that he did showed that AFP has raised, and his ears are raised and is alarmed that an AFP which normal values for 0.8 goes up to 28. He underwent a sonography which shows a nodular liver which was same as before, and all of a sudden he calls his gastroenterologist, and gastroenterologist out of town. So he revisits his old found family physician, Dr. Sangvi, and calls him. Sir, this is the report. I've gotten high AFP, sir. What should we do? So, Doctor, my gastroenterologist is out of town, and what should I do? Is it an urgent thing? What should Dr. Sangvi do? Dr. Sangvi is in the middle of a vacation on a Saturday, Sunday with his family. Should Dr. Sangvi cancel that vacation, come back, and see the patient on an urgent basis and advise him something? I think it's a hepatitis C hepatitis C viral infection that has been there since years. He has a nodular liver. A sonography does not show a mass. AFP is risen. Again, a CT scan is what we should advise, a triple phase CT scan, telling us that this is not an urgent situation, but yes, you can do a CT scan on Monday morning, understand that whether there is any lesions that are found in the liver that can collaborate with the AFP levels, and then we can take it further from there. So Dr. Sangvi does not need to cancel his vacation. He can tell the patient to relax and come back in Monday morning and understand what further we can do. Right. Moving on to the fourth case, 43-year-old male complains of dyspepsia since 3 years. Advised to undergo a ogiriscopy, found to have a submucosal lesion, biopsied, histopathology suggestive of a neuroendocrine tumor with a MIB index of 1 to 2%. Dangerous words, Googled, and the first thing that we see, neuro what tumor? A tumor involving the brain, a brain in the stomach. What they are confused. They booked a PET scan for tomorrow, and they call up Dr. Khan and meet him tonight. What should Dr. Khan do? So what should Dr. Khan's advice be? So again, coming to the point that when they do an endoscopy, a submucosal lesion which shows a neuroendocrine tumor, it is nothing to do with the brain. It is something of a differentiation of a tumor, which is called a neuroendocrine tumor, which is a different type of, like adenocarcinomas, squamous carcinomas. There are neuroendocrine tumors. They arise from the gut mucosa only, and they are most slow growing tumors with a MIB of 1.2. His survival could be 10 years, 15 years. These are the tumors that are very commonly long-term survivors. You must have heard of Steve Jobs, the Apple founder. He had neuroendocrine tumor of grade 1 and survived for 13 long years, and that too after refusing therapy in the initial years. So that is how neuroendocrine tumors behave, and they're very slow growing. PET scan will not help him because these neuroendocrine tumor express a somatostatin receptor. We should not be doing a simple PET scan. We should be doing what is called as DOTA scan. PET scan will not help in these tumors. They will not tell us where the disease is. A DOTA PET CT scan will be done, and that will tell us that this is a neuroendocrine tumor and where all it has spread. So a PET scan should not be done, and that is what Dr. Khan should advise his patient. Coming to the last case, I think a 62-year-old female complains of abdominal distension and pain since few weeks. CT abdomen plus pelvis suggestive of bilateral adnexal masses, gross ascites, peritoneal thickening, ascitic fluid, tap twice, cytology negative, backtech negative, CA125 212, CEA is 12, and CA199 is 116. So obviously, with bilateral adnexal masses, gross ascites, and peritoneal thickening, there could be ovarian cancer that we are suspecting. But here we need to be very sure that these bilateral masses are from the ovary only. We'll have to be sure how, because these adnexal masses can also be a Krukenberg tumor, wherein they can come from the abdominal tumor, or in a stomach cancer can go to adnexa and lead to a bilateral adnexal mass with similar findings. And we may miss the small stomach primary and treat it as an ovarian cancer. However, they would be a stomach cancer which has metastasized to the ovary, right? There could be also other like breast cancer, colon cancer. They all metastasize to ovary and they form Krukenberg's tumor, which are bilateral adnexal masses shown on the CT scan. And these colon cancers and stomach cancer, being mucosal lesions, are missed on the scan. So that is why we should always do a colonoscopy and an endoscopy in patients with bilateral adnexal masses, and not just come to a conclusion that these are ovarian cancers only, right? So need to rule out colon cancer and stomach cancer in these cases cannot be stressed on more. This is very important. So that is what family doctor Thakur should tell them, that it looks crystal clear currently, but still I would want to get a colonoscopy and an endoscopy to rule out colon and stomach cancer. Right. So coming to the last case, 34-year-old male presents with low-grade fever since 3 weeks, new in the city, has visited 3 GP, 3 general practitioners, 5 days of antibiotics each has been giving them. The patient does not uh, tend to have reduction in symptoms. He now visits Dr. Hegde. He has undergone a CBC, urine routine, SGPT, Vidal, creatinine, USG, abdomen. And the reports are as CBC showing a WBC, leukocytosis, that we discussed in my initial lecture, basophilia of 6%, Vidal test is positive, SGPT is 51, creat is normal, and USG shows mild splenomegaly. A Vidal positive, mild splenomegaly, constant fever. I am sure everyone is going to typhoid and treating typhoid with multiple antibiotics for a longer duration, of course. But one thing that we tend to miss here is a WBC count of 19,880 does not support, typhoid. Second, a basophilia of 6% does not support typhoid, and his low grade fever does not support typhoid. So these are 3 things that we easily tend to miss and are misguided by Vidal positivity and a mild splenomegaly. And we see that that these patients would be treated as infectious complications and given multiple antibiotics, and ultimately when they meet us, we see that these WBC counts are not infectious. They are a CML, a chronic myeloproliferative neoplasm, that I alluded to in the last talk, that these WBC counts are raised because it is a CML, a chronic myeloid leukemia, which needs to be treated with an oral tablet called imatinib. And if that is done, a bone marrow test is required to prove that. Once we do that, we put them on imatinib and these counts are normal, patient is normal, splenomegaly settles, and they can have a long-term survival with that, and we do not need to give any antibiotics. So I conclude that these tests, these situations, scenarios are different, and there are many other scenarios that are there which can be discussed later at a later date in a next lecture. But these topics are because we want to open a Pandora's box, wherein these different mix and match of symptoms and diagnosis, where we can, as family physicians, be confident enough of telling our patients that these are the symptoms and this is what you should do, and then meet a oncologist to help you guide the process through. Thank you so much for your patient hearing. I end my talk here. Thank you.
Thank you. Thank you, Dr. Maheshwari, for the nice presentation. I don't think we have any questions. We'll move on to
I have one. I have one question.
Okay.
Hi.
Hi.
Hi. So, at times, we are really compelled by high-risk patients to do a kind of cancer panel check. Patients who are probably smokers or who had a family history or some kind of exposure to some kind of carcinogen or hepatitis B patients, or and we're really compelled, and we really think that we may want to do a alpha fetoprotein test or a prostate-specific antigen test or carcinoembryonic, and any of these common tests. So what do you advise? Should we do them?
So I'll tell you, sir. It's very difficult to give them a specific test because there are specific screening protocols that we see in these patients, and in India, mass screening has provided no better results than just doing a targeted screening. As in, suppose a high risk patient for lung cancer is who has had more than 20 smoking years, who has had a past history of radiation to the lungs. So these are high risk cancer patients wherein we can get a low dose CT scan done in those patients at an interval of around 2 years, and that can help us detect these patients with early detection of lung cancer. I was a part of a clinical trial wherein we did this, and we detected these tumors and did a trial where low dose CT scan was used as surveillance. Second is, if you have a HCV patient, a hepatitis B patient, yes, if they are long standing and if we see anything on the sonography that we do routinely, then we should definitely do a targeted testing rather than just blindly doing these tests on patients' request. I think cancer panel, full body test, and all of these tests, will give you additional advantage in with respect to diagnosing cancer early.
Thank you, sir.
Thank you.
Dr. Seema is going to be now the next speaker. So I request our Assistant Secretary, IMA CGP, Dr. Kajal Ahuja, to please introduce Dr. Seema.
Dr. Seema Jagyasi is a consultant medical oncologist at Mumbai OncoCare Center, Camps Corner. She also has an experience of working at Prince Ali Khan Hospital and Breach Candy Hospital for over 4 years before coming to MOC. She did her MBBS from Terna Medical College, Navi Mumbai, followed by DNB in General Medicine from Breach Candy Hospital, Mumbai, and DNB in Medical Oncology from Prince Ali Khan Hospital, Mumbai. She has a strong inclination in cancer research and has many publications and research papers to her credit. Dr. Seema has a keen interest in treating solid tumors like breast cancer, ovarian cancer, lung cancer, cervical cancer, gastric and colorectal cancers, as well as all types of hematological malignancies. Today, she'll be speaking on recent advances in the management of gynecological malignancy. Over to Dr. Seema Jagyasi.
Good morning, all the seniors and colleagues. Am I audible clearly?
Yes. You can share your screen.
So
yes, it's seen.
Today, my topic of the topic which I will discuss is about the recent advances in the breast cancer. But before going to recent advances in breast cancer, recent advances in the management of gynecologic cancers. So before going to recent advances in the gynec cancers, first we will touch upon some basics in the management of gynec cancers. So gynec cancers, basically they involve mainly ovarian cancers, and other gynec cancers are uterine cancer and cervical cancer, and other uncommon cancers are also there, which we will not discuss today. So mainly we'll discuss first about the ovarian cancer. So whenever we are getting, the family physicians are getting any females who are presenting with ovarian cancer, how they present. Actually, unfortunately, there is a lot of free space in the abdomen. So the ovarian cancers keep growing and then they don't produce any symptoms in the stage 1 or stage 2 of the malignancy. By the time the patients present with ascites, distension of abdomen, constipation, they are already in stage 3. So that time they already have ascites, and many of them are inoperable, and they need to be treated with the neoadjuvant chemotherapy to downstage the cancer and then subject them to surgery. So when investigating any patient with any female, particularly post-menopausal, we have when they present with constipation, backache, or ascites, first we should tell them to do sonography of abdomen. If ascites is present or any adnexal masses are suspected, then we should advise them to do CT abdomen pelvis with contrast. PET scan has limited role in diagnosing ovarian cancer. So PET scan should be avoided in cases where ovarian cancers are suspected, because it does not give any added information apart from the routine CT scan with contrast. So we advise them CT scan, and if it has the signs of inoperability, that is gross ascites with pleural effusion, or the lesions reaching up to the liver or spleen, then it is inoperable, and we subject them to neoadjuvant chemotherapy to downstage these cancers. Another important aspect here is whenever we want the tissue diagnosis for a ovarian cancer, we should do ascitic tapping and do the cytology of those cells and do the test on those ascitic fluid cells, rather than we should avoid doing the biopsies over here. So if ascites is present, we should do the ascitic fluid cytology, or we can do the omental or peritoneal nodules are there on CT, we can biopsy them. Because in early adnexal masses in stage 1, stage 2, we should avoid directly doing the CT guided biopsies, as they can upstage these masses, and they can cause the rupture of the ovarian capsule. So if luckily some patient presents in early stage ovarian masses, like picked up on a routine health checkup, we should refer to gynec oncosurgeon, and we should avoid the biopsy, and we should straight subject her to surgery from all the clinical scenario, and at the time of surgery the frozen section should be done. So that is one basic. Another thing is now coming to the advances in the treatment of the ovarian cancer. So in last decade, there have been a lot of advances in the management of ovarian cancer. In the past, the main modalities of treatment used to be surgery and chemotherapy. Now we have targeted drugs against ovarian cancer, and radiation has has practically no role in the management of ovarian cancer. So now in recent advances, we have the targeted agents which target the particular mutations or the particular driven pathways, so that they can kill only the cancer cells and have minimal toxicity on the normal body cells. So whenever we are dealing with the ovarian cancers, that is the high-grade serous carcinoma, which is most common, we should subject all of these patients to BRCA testing. Now there are two types of BRCA gene testing. One is somatic testing and one is the germline testing. Germline testing is done from the blood and somatic testing is done from the tumor tissue. So before subjecting any patient's tissue or blood to the test, first we should counsel the patient and the family. That is called as pre-test counseling. We usually call the genetic counselor. In our team, we have Dr. Divya. So she discusses in details the pros and cons of these tests, and so that they don't have the anxiety about the results. So pre-test counseling is done, and then germline or somatic test, whichever is indicated in a particular patient, we do that. And after the results are out, again we call them for post-test counseling. So now ovarian cancer causes more deaths than any other cancers of the female reproductive system, and 85% of ovarian cancers are sporadic, but 15% of ovarian cancers are familial. So we can do something about these familial cancers. We can at least if we cannot prevent them, we can diagnose them in initial stages and we can prolong their survivals. So the most common genes over here which are mutated are BRCA1 and BRCA2, which can be easily detected with the tests which are readily available now. And initially, few years back, the cost of this BRCA1 and BRCA2 tests were very high, but now the costs have come down and they are within the reach of the normal public, normal population also who are suffering from cancer. Again, I should stress here that these are not for general population. These are only for the patients who are suffering from ovarian cancer, breast cancer, prostate cancer, pancreatic cancer, or the after testing the patient, if the patient test is coming positive, then for the first degree relatives of the patient, not for general population. So most ovarian cancers, there is one particular character of ovarian cancer that they keep recurring. And most of these ovarian cancers, they will recur again and again. Then this leads to poor prognosis and shorter treatment intervals. So whenever we are giving any treatment in the first line, it will have the PFS of say around 1.5 years. And PFS, progression-free survival, keeps on reducing with the subsequent lines of treatment. So these carriers of BRCA1 and BRCA2 mutations, they have a higher risk of developing cancers than the general population. So mainly here they have the risk of breast cancer, ovary cancer, prostate or pancreatic cancer. So sometimes we do BRCA mutation even in the males when we are handling the patients who are suffering from prostate cancer, having strong family history. Then in those prostate cancer patients also we advise BRCA testing. So whenever a patient is harboring BRCA1 mutation, they have 65% chances of developing breast cancer, 45% chances of developing breast cancer in BRCA2 mutation. And whenever patient is having BRCA1 mutation, they have 39% chance of developing ovarian cancer in their lifetime. Patients with BRCA2 mutation have 11% risk of developing ovarian cancer. So now, these BRCA testing, why do we do? Because it acts as a predictive factor. So patients who are suffering from ovarian cancers, these BRCA gene testing can identify that they are sensitive to some drugs called as PARP inhibitors or some chemotherapeutic agents like cisplatin. They will work better in these cases. And other is a prognostic factor. It is important prognostic factor because along with the other prognostic factors like diagnosis, histology, extent of surgical debulking, because the patients with BRCA can have sometimes very stormy course and they can develop resistant and very aggressive disease. And risk assessment is the third aspect. So this also can help to identify the women in their family who are at increased risk for developing breast or ovarian cancer in future. So whenever we are referring for BRCA testing, first we take a detailed family history, at what age the patients have been diagnosed with the cancer, what is the histologic type of the cancer. So sometimes when we do BRCA testing, some patients may have even no family history or ovarian, and these are categorized as low risk. So in patients with ovarian cancer, the family history and age at diagnosis are poor predictors of BRCA mutation status. And up to 40% of BRCA mutation can be missed if the testing is only performed in women with a history of breast and ovarian cancer. So now there are two types of tests available, germline and somatic. Germline is done on the blood and the somatic testing is done on the tumor tissue. So which type of sample to test? So germline, these are present in the blood, so which can be detected, and these are inherited from one of the parent, and the subsequent acquisition of inactivating mutation in the remaining wild type of the copy of gene leads to loss of function. So these are originating from the germline cells, germinal cells, that is the eggs or sperm, and they are transmitted at the conception to offspring, and they are replicated in the cells of the body. So somatic and other testing is somatic mutation. These are not present at the birth of the offspring. These are acquired during the individual's life, and they are present only in the cells descended from the cell in which the mutation originated, and these are not heritable. So these are to be done from the tumor tissue which has been removed during the surgery or from the biopsy tissue. So only tumor BRCA testing enables the and from tumor we can find out both the, if we are studying the tumor cells, we can find out both germline and somatic mutations. So now how to interpret these results of the BRCA testing and what are their clinical implications? It is not very easy to, these are very complicated tests and very elaborated tests. So to interpret these results is not very easy, that whether it is positive or negative. Sometimes we have difficulties in interpreting these tests called as VUS, which I'll tell you. So whenever the BRCA1 or BRCA2 test is positive, then we do the genetic counseling, and then we discuss with the family about the results and what steps they can take. So here when we are reading any result, there are some pathologic variant, that is the deleterious mutation. There are suspected deleterious mutation like likely pathogenic. These are clinically important and which should be discussed with the patient. Then there is some entity called as VUS, variant of uncertain significance. So this has unknown significance. These are mutations. These are mutations, but then they don't have any clinical importance about with the underlying malignancy. They may not be associated. These are picked up from the tissue, but they don't have any significance. So these VUS, they will cause unnecessary anxiety with the patient, and others are having no clinical importance. These are likely benign or benign. So mainly which are important over here are deleterious or suspected deleterious, that is pathogenic or likely pathogenic mutations. So the results comes in this format. So sometimes there are, whenever the results come variant of uncertain significance, there is a lot of anxiety with the patients and the family members, and these also have the ethical issues. So here we have to take this very carefully, and we should not end up in causing more mental trauma to the patient. So whenever the genetic test report has deleterious, that means it is associated with malignancy. When no mutation is detected, that means the patient is not harboring particular mutation. And whenever VUS is detected, that is a complicated scenario. So then how to handle that? There are other methods. So we have drugs called PARP inhibitors, that is olaparib and rucaparib and others, which are used in the management of breast cancer, and they have shown the improvement in the survival, particularly in the advanced stages of ovarian cancer. They are used either in metastatic setting or in the adjuvant setting as maintenance therapy, and their role is now evolving more and more. So these we have particular targets where we get the help of from the BRCA test. So take-home messages are test all the ovarian cancer patients, irrespective of their age and family history, for BRCA status. And BRCA testing allows us to make informed and timely clinical management decisions. Only tumor BRCA testing enables the detection of both germline and somatic mutations. Pathologic variants confer increased risk of disease, which can have implication for treatment and prognosis. And olaparib and other PARP inhibitors have led to substantial, unprecedented improvement in progression-free survival with newly diagnosed patients of ovarian cancers. Another thing in this is in the management of ovarian cancer. So in the recent advances, we have these PARP inhibitors and BRCA gene testing. And there is one test called next generation sequencing. Next generation sequencing, where we do the detailed molecular analysis and we study what genetic alterations are happening in a particular patient's cancer, which can offer some novel in which we can offer some novel therapies which are not routinely used in a particular type of cancer. But now, as all the cancers are getting more and more with the personalized care, so every cancer patient is different. Two ovarian cancer patients will not respond to the similar chemotherapy. So now the other recent advance which is coming is the next generation sequencing, which we are applying in most of the cancers, solid cancers. So we can use those information. Those tests are expensive, but then they give additional information, additional targets, and additional novel therapies they can suggest, which we can use when all other therapies have already been used in the previous lines of treatments. Thank you. And any doubts regarding this gynec cancers or these testings, please.
Yes, madam. That was a very detailed talk. I mean, BRCA genes is, as you said, very difficult to
Analyze
give a prediction. Yes. So exactly you have mentioned, but when should the BRCA testing be done? At what age? For say
for
there's a family history.
for ovarian cancers, high risk serous ovarian cancers, all patients of high risk, high grade ovarian cancer should be subjected to BRCA testing. It is not in breast cancer. All breast cancers may not be subjected, but in high grade serous ovarian cancers, all the patients should be suspected ideally to the BRCA gene test.
So BRCA1 or BRCA2, do they have a role in the pathogenicity of genetic basis of breast cancer?
BRCA1 and BRCA2. Also, there is a similar HRD panel. That is the sometimes the BRCA1 and BRCA2 are negative, but HRD panel, there are some genes which are BRCA-like action. So even those we advise in our panel, because why we are advising and stressing so much in ovarian cancer, because these targets, PARP inhibitors, are available for routine use, and we can use them when all other chemotherapies have been exhausted, or some patients are not fit for chemotherapy. We can use these agents. These are oral tablets which are available in India, and they make life easy and improve the quality of life also.
So now, madam, the next speaker is Dr. Darshana Rane, but she doesn't seem to be online. We are trying to contact her. Any idea about her whereabouts? I mean, Dr. Udip, are you there?
Sir, give me 1 minute.
Okay, meanwhile, madam, can you just elaborate a little bit on breast cancers? She, I think, taking some time to join in, maybe 5 minutes. Could you continue and give us an overview of the breast cancer?
Whenever we are dealing with the breast cancer patients, whenever a lady presents with a breast lump, sir,
how do we approach? As a general practitioner, how do we approach?
Yes,
a very grassroots
one point I missed in ovarian cancer. I will take 1 minute. whenever the post-menopausal females are presenting with ovarian adnexal masses, they are high-grade ovarian serous carcinomas. But when young pre-menopausal ladies, young girls are presenting with adnexal masses or distension of abdomen, or on sonography, they get picked up. These are germ cell tumors. Like how we have in males the testicular seminoma or non-seminomatous, in females we have germ cell tumors. They occur in younger girls, unmarried girls also, and they have a different treatment, different chemotherapy, but then they have very good chance of getting cured. Germ cell tumors can be cured and they can live the normal life also, these girls, after their cure. So, and in them, we have fertility sparing surgeries also. We remove only one ovary, we don't remove both the ovaries. We keep the second ovary if it is normal, so that they can later have their reproductive life also.
Correct, correct.
So in young female, we should suspect germ cell tumors. In elderly patients or menopausal or near menopause, we should suspect carcinoma of the ovary. There we remove both the ovaries,
Both the
uterus, fallopian tubes, everything. So
Right,
this, so even young girls can present with ovarian malignancy, but mostly they are germ cell tumors, and which can be managed much easily than ovarian cancers. And in germ cell tumors, we need not do BRCA testing.
Okay.
Now coming to breast cancer. So whenever a lady comes to family physician or a gynec doctor with a breast lump, breast cancer lumps, as we all know, they are mostly painless. In initial stages, they are painless. Most of them are painless, which they miss for 3 months. And then only when in the later stages they develop some pain or the lumps increase, that time they come to the doctor. So they are all painless. As soon as they come, first we should examine, and on examining, if we feel they are soft, mobile, we should suspect fibroadenoma. If there is nipple discharge, we should suspect papilloma or some other. But if they are hard lump, fixed lump or a hard lump, then we should suspect malignancy. Even now, younger girls are presenting with malignancy. Yesterday, I saw a 28-year-old chartered accountant student presenting with a breast lump which got misdiagnosed as breast abscess for few months. 28-year-old girl, finally when she got diagnosed with breast cancer, she already had liver mets, and she's still studying the CA course. So even now, unfortunately, we are seeing breast cancers in young females, sometimes unmarried females also. So we should, whenever a hard lump is felt, we should immediately advise on mammography and biopsy. And biopsy gives more information because sometimes FNACs, they may not pick up all the cancers. So wherever possible, we should advise them USG guided two-cut biopsy, because in breast cancers, they will not upstage the doing biopsies, they will not upstage the cancer as in ovarian cancer. So we should advise biopsy, and as soon as if it shows ductal carcinoma or lobular carcinoma, we should immediately refer to an oncologist. So another thing is in breast cancer, there are grossly 4 types of breast cancer. Some are hormone positive, some are hormone negative, and some are HER2 positive. So the treatment of all the 4 types of breast cancers are different. Some have very good, excellent prognosis. ERPR positive and HER2 negative, they have excellent prognosis. And whereas triple negative, when ERPR and HER2 all are negative, they have very bad prognosis. Sometimes the patient may not even pull on for 1 to 2 years. So, and HER2 positive cancers, they have a agent called as trastuzumab, which can be used in their management, and they have more propensity of developing brain metastasis. So this is all. There are 4 types of breast cancer.
Can you tell us something more about uterine cancers, ma'am?
Sir, uterine cancers, these are the endometrial cancers. So whenever a lady is presenting with postmenopausal bleeding or postmenopausal discharge, we should do their sonography, like transvaginal sonography. And whenever we feel that the endometrial thickness is more and when in postmenopausal age it should not be there, we should advise them DNC. and we should subject the tissue for the histopathology. And in histopathology, if it comes out to be endometrial cancer, then we should advise them to go to oncosurgeon or oncophysician, and then we should plan their surgery, in which uterus with cervix and ovaries, everything is removed. And then based on the histopathology report, how much the tumor had invaded, whether less than half of myometrium or more than half of myometrium, and what was the stage, histopathologic stage, then we decide in future whether they need additional radiotherapy or they need additional chemotherapy after the surgery.
Right. So what is the cutoff point of the endometrial thickness which you suspect?
Sir, the stage, there here in endometrial, there are two things which are involved. One is the stage and the grade. So there is grade 1, grade 2, grade 3, and which is on the microscopy. And stage 1, stage 2, stage 3, and stage 4, which is based on the invasion of the myometrium and spread to the adjacent lymph nodes, or stage spread to other like vaginal tissue and other things. So in first stage, in grade 1, sometimes we don't advise them any adjuvant treatment, but in stage 1, in grade 2, grade 3, we advise them additional brachytherapy, that is the internal radiation therapy.
Yeah.
And as the stage advances, then external beam radiation also we advise. And in stage 3, we advise them additional chemotherapy, adjuvant chemotherapy, and also along with the radiation therapy.
So there is target therapy available in this?
Yes, and in metastatic endometrial cancers, when they have spread to other organs of the body, like in the liver or other tissues, then, sir, we again, if patients are affording, we do next generation sequencing, NGS testing. These are the molecular tests. These tests can be done in India as well, or sometimes the tissue is sent abroad for the testing. And these test results, they take 2 to 3 weeks, where they analyze the tumor tissue to the molecular level, what mutations are present, and they suggest that this mutation is present, so we can use this particular therapy in this mutation. Dr. Darshana has joined, I think. So now we will.
Yes. Thank you very much. Yes. Thank you very much, madam. There was a wonderful discussion and interaction with you. Thank you so much.
Thank you, sir.
Darshana, you're most welcome on the screen. And I request our CGP member, Dr. Kashyap Dakshini, to please introduce Dr. Darshana.
Hi friends. Dr. Darshana Rane is a consultant medical oncologist at Mumbai Oncology Center, Dadar. She is also attached to Sushrusha Hospital, Dhanvantari Hospital, Vokad Hospital, Bombay Central, HCG Borivali, Surya Hospital, Andheri, and Nanavati Super Speciality Hospital, where she is a consultant medical oncologist. Dr. Rane pursued her MBBS from Terna Medical College, MUHS, DNB Internal Medicine from KEM Hospital, Pune, followed by DNB in Medical Oncology and Hemato-Oncology from Prince Ali Khan Hospital, Mumbai. Dr. Rane then received the European Society certification in Medical Oncology. She's an esteemed member of the American Society of Clinical Oncology and the European Society for Medical Oncology. Her areas of interest are chemotherapy, acute lymphocytic leukemia, breast biopsy, cervical cancer treatment, endometrial cancer treatment, leukemia in children, liver cancer, lung cancer, etc. Today, Dr. Rane will speak on the changing paradigms in the management of breast cancer. Over to Dr. Rane.
Thank you so much for a warm welcome. Now, because of the lack of time, I will start off my lecture. Can I present the screen?
Sure. Yeah, you can share the screen.
Can I request someone to share the screen for me?
Okay. Piyush.
Yes, sir.
Can you do screen sharing for Darshana?
Well, I don't have the presentation.
Oh, ma'am, you have to do the screen sharing yourself. You have the presentation, no?
Actually, I'm logged in from a mobile, so
Oh, okay.
not able to share. Can I share it through somebody? Like, if the organizer can just send me a hello, I can just immediately send the CME.
Piyush?
Yeah, on it.
Yeah. Can you do it, Piyush?
Yes, sir. Ma'am, could you please type in your phone number to me? Thank you, everybody. Ma'am, I've texted you on WhatsApp. Now I request.
Are you getting it?
Yes, sir, getting it on this device.
Okay. You'll have to unmute yourself, Dr. Darshana. Please unmute yourself.
Sorry. So I will be discussing certain aspects of breast cancer today. What are the new paradigm changes that we have seen nowadays? So breast cancer, as we know, is a very commonly seen illness today. And what we commonly used to do is a FNAC earlier. But now let me tell you all, FNAC is no more done. It is the biopsy, which is very, very important. And it has got the both therapeutic as well as prognostic implication. The staging also has changed as per the what receptor positivity we see. So with this, as the presentation has started, next slide, please. Next slide, please. So as we all know that breast cancer is the most common cancer in the female population. Next slide. And 1 in 28 women will be seen to be diagnosed with breast cancer in India. And it's a leading cause of death in women of breast cancer. Next slide. So age groups, so what is the difference that we have seen in India currently? There is a change in the age group of incidence. Earlier, we used to see all cancers and especially breast cancer in the elderly population, but now it's not so. Now we see breast cancer as early as 25 and 30, and that is the most common, the young adults is the most common age group in which we see this breast cancer today. Next slide, please. Survival, this is a chart showing a 5-year survival, and as we see the stage 0, the carcinoma in situ, breast cancer has 100% survival, and stage 1 98%, and stage 4, that is the metastatic, has got 22% overall survival. But this also has been modified with the advent of newer treatment options. Next slide, please. So there are three important subtypes which are seen clinically, and for this we have to understand the receptor status that is seen on the breast cancer lesion, which we do on a biopsy. So biopsy is very important, and immunohistochemical staining for this estrogen receptors and the progesterone receptors and the HER2 receptor is very, very important in subtyping of the breast cancer. So we have the HER2 or we have the hormone receptor positive cancers as a major subtype, accounting 60 to 70%, followed by 25 to 30% in the HER2 population. And those tumors with no receptor positive status has 10 to 15% incidence. Next slide, please. This is a representation of the survival as per the subtypes, and in all subtypes we and all the stages we see that the best survival is seen in those tumors with a HER2 positive subtype in all stages. And because with the advent of the latest treatment options, we are seeing very, very excellent responses. And the worst subtype is the triple negative in all stages. Next slide. So earlier we had this differentiation of good subtype and bad subtype, in which the HER2 also was noted as a poor prognostic group. And this is very important that if it's not treated by an anti-HER2 agent, it is indeed a poor prognostic group apart from the triple negative. And it's shown to progress very aggressively and metastasize also if not treated with anti-HER2 agent. Next slide, please. So it is very important that we understand what treatment options and when to actually time them. So we all know breast cancer, the treatment options, surgery, chemotherapy, or any systemic therapy and radiation from the main backbone. But when to sequence the chemotherapy is a very, very important question. Now, earlier, what was happening is all the patients would go to a surgeon, get the cancer removed, and then come to us. Now, the timing of chemotherapy is a bit changed. Now, it is not only left to after surgery, that is adjuvant. Now, the concept of neoadjuvant is very, very highlighted and important. And that is a real paradigm shift that we have seen today. So now chemotherapy, surgery, radiation therapy followed by hormonal therapy is the new way to go. Next slide, please. Next slide, please. So earlier, neoadjuvant therapy was restricted to those large tumors as a palliative option. Subsequently, we came to know that these tumors, which are large, could be made operable, and hence in stage 2, 3, they were used commonly. But now the concept of neoadjuvant therapy is to achieve a pathological complete response and not just to downsize. Why? Because the pathological complete response is seen to show a good event-free survival and disease-free. So the survival benefits are seen. Next slide, please. So neoadjuvant therapy, one, it helps to reduce the metastasis. That is a distant spread. Documentation of pathological complete response. What is pathological complete response? It means that after giving this treatment, if the patient is subjected to a surgery on the tumor, we do not see any tumor on the operated sample. That is known as pathological complete response. And this is very important that neoadjuvant therapy helps in downsizing the tumor. So surgical outcomes are how they are improved. Those tumors which were large, they are now made operable. Those tumors which required extensive surgeries, now we could deal them with a breast conservation surgery and they would have a better cosmetic outcome. Next slide, please. So this is a very busy slide, but the gist is long-term outcomes for neoadjuvant therapy versus adjuvant therapy, even in the early breast cancers, are shown here, and it's shown that all subtypes, all stages, they show a better response with the neoadjuvant therapy, especially in the triple negative and the HER2 subset. Next slide. Next slide, please. So there's a strong association between this pathological complete response and both the event-free survival and the overall survival of the breast cancer population. Next slide, please. Next slide, please. So this is again the association between the pathological complete response and the event-free survival by the breast cancer subtype. And we know that the triple negative and the HER2 positive subgroup are the ones which have an excellent response and an excellent pathological complete response and the event-free survival if treated with a neoadjuvant therapy. Next slide, please. So we do have backup of studies for the same. This was the NSABP B18 study also shows the same. Next slide, please. Next slide. And hence, there is an emergence of a de-escalation or escalation concept with the type of response that we see on surgery, whether there's pathological complete response or no. Now we come to this triple negative subset. It's a very tiny population, only 10 to 15% of the population, but it is seen in a very young population. And it's a very aggressive subtype and very, very important diverse subtype. I'm sorry for the disturbance. So triple negative subset is 10 to 15%, and it's a very aggressive subtype. Next slide. So post-operative chemotherapy in patients with residual disease after neoadjuvant therapy was evaluated in a trial known as CreateX trial, in which the stage 3 tumors, which were HER2 negative and hormone subjected to neoadjuvant chemotherapy followed by surgery. And then if there was no pathological complete response, then they were divided into those patients who would receive capecitabine based oral chemotherapy versus observation only. Next slide, please. And what the CreateX showed in the triple negative population, both the event-free survival and the overall survival. So there was a good survival benefit seen in all subtypes. But if you see the lower charts, it was more important in the triple negative subtype, in which they showed excellent responses with the use of this maintenance therapy with capecitabine. Next slide, please. Now we come to this and it is seen in 25 to 30% of the population. Next slide, please. So HER2 positive was supposed to be a very aggressive disease earlier. And I mean, it's still aggressive disease with a poor outcome, but now it does not have a poor outcome. And what is seen, not just for locally advanced breast cancer, but also for early breast cancers, that is tumors more than 2 centimeters who are not positive. And when we use neoadjuvant therapy, that is before a surgery, if we use a chemo and targeted anti-HER2 targeted therapy with agents such as trastuzumab and if affordable pertuzumab, we see excellent responses. Next slide, please. So meta-analysis for relationship between the pathological CR and event-free survival in patients with HER2 positive early breast cancers, it was, as seen in this chart, very, very excellent disease-free survival as well as overall survival rates seen. Next slide, please. So, like in Createx, we had an oral agent for those who did not achieve pathological complete response. We do have additional agents as a building agents to trastuzumab for those HER2 positive tumors who show some residual disease. For example, we have this oral agent, neratinib, and we have intravenous agents. So those who did not receive pertuzumab earlier now could be added on with a pertuzumab to the trastuzumab backbone. We could also switch to another agent, the TDM1, that is the trastuzumab with emtansine, which previously we used to only give it for the metastatic cases. We could give this agent to also those with a pathological, no pathological response with a residual disease in a HER2 positive patient treated with a neoadjuvant treatment. Next slide, please. So HER2 positive stage wise. So early stage, definitely we have to undergo surgery first and then followed by the adjuvant therapy with chemo as well as a targeted agent with trastuzumab and pertuzumab if afforded. As the stage advances and it becomes more locally advanced, neoadjuvant therapy is the way to go. The agents of choice are trastuzumab with or without pertuzumab with the chemotherapy, and trastuzumab typically is continued for 1 year in adjuvant cases. And so also those patients who are treated with a neoadjuvant chemotherapy followed by a surgically, if they have a good pathological complete response, they also receive it for a year. However, if the disease is still there on the tumor which is removed, that is, there is no so if there is a residual disease in the operated specimen, we need to shift to another agent, that is a TDM1, which we give for 14 doses. And if the patient is also additionally hormone receptor positive, endocrine therapy is also clubbed with it as a adjuvant therapy. Next slide, please. So this is a major subtype, ER/PR positive, that is a hormone receptor positive. This subtype does not really respond well to the chemotherapy, but what is available is a very good spectrum of hormone receptor therapy, which we use in such population. Next slide, please. So stage 2 to 3 breast cancer, the pathological complete response is 0 to 8% for luminal A and 15% for luminal B. So not that much of a pathological complete response seen, but we do restrict the NACT to those hormone receptor positive, HER2 receptor negative to just downsize the tumor so as to undergo breast conservation therapy. Next slide, please. Now, we do have certain genomic assays, and these genomic assays are nothing but some special tests which are done on the biopsy block as well as on the blood, so that early breast cancers who are treated with a surgery, we should understand, those who are node negative and hormone receptor positive, we should understand whether we really require chemotherapy in such populations or no. So those tumors which are node negative, hormone receptor positive, if they fall in a very low risk group, then in those populations, we can simply avoid the chemotherapy and only use hormonal therapy. Next slide, please. Now, metastatic breast cancer. This is very important to understand that metastatic breast cancer does not mean that the breast tumor should be of a very large size. So even a small size tumor can show metastasis. Metastasis need not mean that a tumor should be in any viscera or the bone. Even the nodes which are non-regional can be also, if positive, it can also mean a metastatic disease. Next slide, please. So targeted therapies for HER2 positive breast cancer. So as we know that HER2 positive tumor, very aggressive disease, but we have a real wide spectrum of therapeutic options available. So HER2 positive, HER2, what is HER2? HER2 is a receptor which is there in normal cells as well, but in breast cancer lesions, it is overexpressed. So there are more receptors present, and hence we can use these agents, anti-HER2 agents, to target these particular cells in particular. So be it anywhere in the body, the targeted agents work as a systemic therapy. So some agents are there which are working on the HER2 targeted therapy as a HER2 as a some agent. Just 1 second, give me a minute. I'm sorry for the technical glitch. For HER2 positive breast cancer therapies, we have intravenous agents which work on these receptors, and we have oral agents also which work on the downstream pathway of these receptors. So these intravenous agents, we have trastuzumab, pertuzumab, TDM1, and for the ones which work at the downstream pathway, we have certain agents like neratinib, lapatinib, and tucatinib. Especially tucatinib is something which we can use for those tumors which are also metastasized to the brain. So although it being an oral agent, it can penetrate the brain well. There are other chemotherapeutic agents which work on the mTOR pathway, the everolimus and the temsirolimus, that also can be used in any type of breast cancer. Next slide, please. So what is the treatment algorithm for this HER2 patients? So we don't have only one, we have multiple agents. So neoadjuvant, trastuzumab, pertuzumab, subsequent line we have TDM1, and still we on the further subsequent line we have a whole list of agents in which we have trastuzumab, emtansine, tucatinib, and capecitabine combination with trastuzumab, capecitabine neratinib combination, and so on and so forth. So there's a whole lot of newer anti-HER2 agents which are available in case one line fails. Next slide, please. Triple negative subset is not a single entity. Triple negative subset is a broad spectrum wherein we have clinically less aggressive as well as more aggressive tumors, and these tumors are treated by only agents that are chemotherapy. But those patients who are affording and those patients who can take those costly medicines like immunotherapy and special targeted therapy, we do offer certain further testing on these tumors the tissue sample, for which we do this androgen receptor, PI3K receptor, and other PDL1 receptor testing. Some tests can be done by immunohistochemistry, but certain tests require a more costlier test like the next generation sequencing method to further subtype them into what is the receptor status and what we can use it as a target. Next slide, please. So hormone receptor positive, initially we had only the hormone receptor targeting agents like the non-steroidal aromatase inhibitors like anastrozole, letrozole, steroidal aromatase inhibitors like exemestane, estrogen receptor down regulators like fulvestrant, selective estrogen receptor modulators like tamoxifen. But now we have even targeted agents in these type of tumors, that is the the hormone receptor positive tumors, we have targeted agents also. And what are these agents? They are namely the anti-CDK4 inhibitors, CDK4 and 6 inhibitor agents like palbociclib, abemaciclib, ribociclib, PI3K inhibitors like alpelisib, and mTOR inhibitors, which we saw earlier, the everolimus. So these are the newer agents, and certain these agents, they have excellent response. So these are clubbed with the hormonal agents, and the response that we see on PET is as good as near complete response. So they work as good as chemotherapeutic agents in case of any cancer. Next slide, please. So here is some experience that I have to share. So neoadjuvant treatment works very well, and as we see, this is a HER2 positive locally advanced breast cancer, and in the second side, if you can see that yellow orange uptake on the breast is totally absent now. It's showing an extensively, it's a very excellent response noted. So this highlights the need of using clips and radioactive clips for noting the tumor dimension before we give such agents, because we get such good response that the surgeon finds it difficult to understand where the tumor is. So we have to clip it to help the surgeon note which was the original site for us to plan the surgery accordingly. Next slide, please. So same patient, what we see, not just on the PET CT, but also on the surgical sample, there was no residual tumor seen. Next slide, please. So HER2 positive LABC, again, as we see, there's an extensive disease extending right up to the axilla, and then on the previous response is very good. So the yellow orange thing. So actually, here the slides are reversed. The first is post-treatment response, and the subsequent is pre-treatment response. So pre-treatment disease has gone now almost negligible. So very, again, excellent response. Next slide, please. This is a triple negative patient. Again, this is another subset which is very good, shows with good response to systemic chemotherapy. So pre-treatment, as we see, a large, bulky mass in the breast, and post-treatment, it has almost vanished with the metabolic activity also gone. Next slide, please. So what are the take-home messages? Take-home messages is early diagnosis is best for better survival. Breast cancer treatment depends on the ER/PR HER2 status, and hence it is very important to do a biopsy and immunohistochemistry, and to understand which agents, which subtypes could be manipulated with a neoadjuvant chemotherapy. All HER2 positive tumors with more than 2 centimeters and lymph node positive patients should undergo neoadjuvant therapy with anti-HER2 agents. All triple negative more than 0.5, they benefit from neoadjuvant chemotherapy. Next slide. Next slide, please. So hormonal positive tumors, NACT is only for those patients who we want to consider downstaging and conversion to a surgery. And pathological complete response is very important. It shows how much survival the patient would have, how much treatment escalation or de-escalation one can do. So breast cancer is seeing a bright future, and there is a very good magnet of targeted therapy that we have, which are less toxic. With that, I thank you for your patient hearing.
Thank you very much, Dr. Darshana. Wonderful presentation. There is a question. Can you tell us what is HER2 new test that is there? What is the difference between HER2 test and HER2 new?
So basically HER2 is nothing but basically these are those receptors, epithelial receptors present on the cell, and they are expressed, they are those VEGF like receptors which are there on the cell, and they are present and expressed normally also. But in case of a breast cancer, these are overexpressed. So because they are overexpressed, we can use them as targets to treat it with the anti-HER2 agents.
Okay, whether HER2 genes are proto-oncogenes or anti-oncogenes?
So they are proto-oncogenes. They
Okay. Any other questions from the panelists? Panelists want to ask any questions? So yes, there are a lot of new medicines available in for all the target therapies. I mean, giving IV, oral, all this is there. But the patient survival also is improved with all these medicines, right? With the target therapy.
Definitely. The ones, as we mentioned, the ones which we thought it was very, very aggressive subset, the HER2, nowadays with anti-HER2 therapy, if it is initiated, the survival are very, very excellent. So the response has been very, very promising.
Right.
Even for triple negative, not all triple negative are very aggressive. And we do have immunotherapy also option in those subset of triple negative breast cancers, which we can use.
Right. So thank you so much, Dr. Darshana.
Thank you, sir.
Yeah, I would now call upon Dr. Kajal Ahuja, our Assistant Director of CGP, to propose a vote of thanks.
I would like to thank our speakers of today's webinar, namely Dr. Udip Maheshwari, Dr. Seema Jagyasi, Dr. Darshana Rane, and Ms. Divya Udyavar. I also thank our knowledge partners for the day, Mr. Saurav Desai, Associate Director, Marketing Cellular Cancer Center Private Limited. I thank Mr. Deepen Mehta, Mr. Piyush Kale, and Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar and handled all the technical details at the same time. A big thank you to Dr. Anil Award for being an MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much, all of you. So we conclude today's webinar. Thank you.
Thanks.
Thank you all. And I was very privileged today to address such a huge population. Thank you.